in therapeutic dentistry. Today we will discuss the next theme. It's a tooth decay definition, epidemiology of caries, prevalence and intensity of caries, increase in intensity, modern ideas about the causes and theories of the development of caries, the essence, advantages and disadvantages, the concept of functional and structural resistance of hard tooth tissue. The main issues for our lecture, it's tooth decay, its definition, epidemiology of caries, World Health Organization epidemiological survey map, modern ideas about the causes and theories of the development of caries, the concept of functional and structural resistance of hard tooth tissues. What about the caries? We know dental caries remains a common chronic disease. In absence of treatment, it may progress until the tooth is destroyed. Despite advances in restorative materials and the implementation of various preventive approaches, more than 90% of adults in the world have experienced dental caries before 30 years of age. Dental caries, it's a multifactorial disease involving many complex risks and protective factors. The clinical presentation of caries disease or caries pathological process is the caries lesion. The severity of the disease and of individual caries lesion is the result of complex personal, biological, behavioral, and environmental factors. Some factors are protective, such as presence of fluoride in the biofilm, whereas others lead to hard tissue destruction, such as lower plaque pH. Caries risk assessment is the organized process of evaluating these protective and pathogenic factors and provide the foundation for selecting treatment interventions. The dental profession continues to implement a more interactive non-surgical therapeutics model to prevent, treat, and reverse caries lesion, particularly in the early stages. Despite progress, the professionals still primarily use the black system for caries classification, referring to the intended surgical operative outcome in classifying the caries lesion. Dr. Black's sorely common when we will engage in practicing preventive rather than reparative dentistry. The World Dental Association caries classification system is designed to help address that goal. Because the caries lesion has different forms of clinical presentation, during their disease process, clinicians need a classification system that support appropriate treatment decisions using available non-surgical and surgical approaches. Classifying lesion location, site of origin, extent, and if possible, activity should be part of all dental evaluations to facilitate risk assessment and treatment recommendation. Epidemiologic studies measuring the prevalence and severity of dental caries have used modified version of clay and collects decayed methane and field of Grubel's decay, the extraction indicated and field indexes. However, these indexes only capture cavitated lesion. Other indexes were designed to describe additional stages of the caries system, ICDAS, which used visual surface characteristics to measure surface changes and potential histologic depth of caries lesion. The bulb, ulcer, fistula, and abscess system, which is focused on staging the most severe levels of caries disease and the caries assessment spectrum and treatment, which includes staging caries lesion both for early and for more severe levels. In 2008, the World Dental Association convened a group of experts and stakeholders to be in the development of CCS that would be used in clinical practice while incorporating up-to-date scientific evidence. This organization Council on Scientific Affairs subsequently, after several interactions, developed the current version of caries lesion classification present in this lecture. This association is intended to be easy to learn, designed for use in various clinical practice settings. It has commonalities and differences with the other caries classification approaches used for clinical caries management and research. The World Dental Association Council on Scientific Affairs ultimately opted to create a new system that takes existing caries classification approaches into consideration, adds additional perspectives, and harmonizes these ideas into a single usable system. This association is designed, this classification by World Dental Association is designed to include non-cavitated and cavitated caries lesion and to describe them by clinical presentation without reference to a specific treatment approach. In addition, the ADA classification contrasted with some caries classification system, links clinical lesion presentation to radiographic findings and provides an approach to identify, when possible, caries lesion activity over time. The World Dental Association Council on Scientific Affairs welcomes and expects feedback from clinicians, dental educators, and researchers in an effort to continue improving the refining the system. The various terms used in this classification and their definitions, it is the next. Caries lesion is the clinical manifestation of caries disease. A patient diagnosed with caries disease can have few or many caries lesions, a clinical manifestation, and the number and extent of these lesions that are measures of disease severity. Based on clinical parameters, each caries lesion may be classified as non-cavitated or cavitated. On the screen, you see this classification and visual features of each type of dental lesion. Sound caries, no clinically detectable lesion. Dental hard tissue appears normal in color, translucency, and gloss. No surface change of adequately restored. Infected dentine known. Appearance of occlusal surfaces, pit and fissures. They are called by ICDAS 0. Accessible smooth surface, including cervical and root, and radiographic presentation of the proximal surface. No radiolucency. The next, it is non-cavitated type of caries. Non-cavitated refers to initial caries lesion development before cavitation occurs. Non-cavitated lesions are characterized by a change in color, glossiness of surface structure as a result of demineralization before there is microscopic breakdown interface to structure. These lesions represent areas with net mineral loss due to an imbalance between demineralization and remineralization processes. Re-establishing a balance between demineralization and remineralization may stop the caries disease process while leaving a visible clinical sign of past diseases. The next type is initial, earliest clinically detectable lesion compatible with mild demineralization. Lesion limited to enamel or to shallow demineralization of cementum dentine. Mildless forms are detectable only after drying. When established and active, lesions may be white or brown, and enamel has lost its normal gloss. Visually non-cavitated, the code by ICDAS 1 or 2, you can see the examples on your screen on the photo. And radiolucency may extend to the dentina enamel junction or other 1/3 of the dentine. Radiographs are not reliable for mild occlusal lesions. The next type, it's a moderate form of caries or cavitated. Moderate clinical presentation has visible signs of enamel breakdown or signs of dentine is moderately demineralized. Established early cavitated, shallow cavitation, and microcavitation. The codes by ICDAS 3 and 4, you can see it on their photos. Radiolucency extend into their radiograph X-ray investigation. Cavitated denotes a loss of surfaces integrity in some cases. Cavitation can be restricted to the enamel, for example, microcavitation. Note that this lesion should be differentiated from a linear enamel hypoplasia and molar and scissor hypomineralization, which are often associated with higher risk of caries disease. Frequently, cavitation refers to the total loss of enamel and exposure of the underlying dentine. In any case, cavitation denotes the inability to biologically replace the loss of hard tissue, and in left untreated, the lesion is likely to progress. And the last type of dental caries lesions, it's advanced caries. Clinical presentation includes enamel is fully cavitated and dentine is exposed. Dentine lesion is deeply, severely demineralized. Other labels, it's a spread, disseminated, late cavitated, deep cavitation. The codes by ICDAS 5 and 6, you can see it on the screen. It's a deep cavities on the teeth surfaces. Surgical refers to removal of tooth structure, usually resulting in placement of restoration. Surgical treatment should be minimally invasive, conserve natural tooth structures, and be provided in conjunction with appropriate non-surgical chemotherapeutic and behavioral interventions. Non-surgical treatment implies use of strategies including physical barriers, that is sealants, biofilm modification, remineralization by means of a chemotherapeutic interventions, and patient behavior change. As stated previously, the decision to treat a caries lesion non-surgically or surgically, often it is made on the basis of whether or not the tooth surface is fully cavitated. The next classification means or shows the stages of tooth decay. You can see it on the screen. The first stage is the bacterial plaque attached to the tooth. A plaque is a biofilm formed by a native bacteria in the mouth. Think of it as city or colony where bacteria associate and clear an environment, create an environment while can be multiply. The next stage of development, the tooth decay, it's acid produced from the bacteria begins to eat away the hard outer layer of the tooth, the enamel. The third stage, it's once though the enamel decay spreads rapidly, though the soft inner layer dentine. And the last stage, it's process spread though dentine decay reaches the inner layer, the innerst layer of the tooth, it is the pulp. The last stage can lead to the complications such as pulpitis or inflammatory process in the tooth chamber, or periodontitis, inflammatory process which exist in the periodontal space. First of all, near the apex, root apex. Description of the American Dental Association caries classification system includes the classification scores. Each surface of the dentition based on the following: tooth surface, presence or absence of a caries lesion, anatomic site of origin, severity of the change, and estimation of lesion activity. Clinical application of this classification relies upon examinations conducted on a clean tooth with the compressed air, adequate lighting, and the use of a rounded explorer or bell end probe. Indicated radiographs also should be available. Detection criteria for tooth surface sites of origin are defined in as follows: pit and fissures, proximal surfaces, cervical and smooth surface, and roots. Sound surface. In the healthy state, the surface is sound and there is no clinically detectable lesion. The dental tissue appears normal in color, translucency, and glossiness, or the tooth has an adequate restoration of sealant with no sign of a caries lesion. Initial caries lesion. They are the earliest detectable lesion compatible with the net mineral loss. They are limited to the enamel or cementum or very outermost layer of dentine on the root surface, and in the mildest forms are detectable only after drying. The clinical presentation includes change in color, white or brown, for example, cervical demineralization along the gingival area, or well-defined areas is a clear change in color to brown, but no sign of significant demineralization in the dentine. That is no underlying dark gray shadow. These initial lesions are considered non-cavitated and with remineralization are reversible. Most of these lesions would be classified as sound in epidemiologic studies. Moderate caries lesion. Moderate mineral loss results in a deeper demineralization with some possibly of enamel surface microcavitation. Early is shallow cavitation and or dentine shadow invisible though the enamel. Which indicates the likelihood of dentine involvement. For example, microcavitation with visible dentine staining. These lesions display readable signs of enamel loss in pits and fissures or smooth surfaces, or visible signs of cementum dentine loss on the root surface. Although the pits may appear intact, yet brown dentine involvement, demineralization may often be detected by their appearance of a dark gray shadow or translucency visible though the enamel. Dentinal involvement or of moderate lesion in proximal areas may be detected in a similar manner by examining the margin ridge over the suspected lesion site, which may have gray discoloration or appear translucent. In the suspected site of an proximal lesion cannot be directly inspected, which is often the case. The presence and extent of lesion cavitation cannot be assessed without the used radiographs to separation or both in combination with an assessment of lesion activity where it's possible. Advanced caries lesion have full cavitation, though the enamel and the dentine is clinically exposed. In the World Dental Association classification, any clearly visible cavitated lesion showing dentine of any surface of the tooth is classified as advanced. In epidemiologic study, these lesions are classified as decayed. Note that any caries lesion described above also may be associated with an existing restoration of cement. Correlating in the appearance of pit and fissure caries lesion relative to suspected histological dentine penetration may be useful in clinical decision making. For pit caries lesion, the ICDAS coordinating committee published data correlating the clinical appearance of three lesions with the histologic examination for the teeth after extraction. Per the published data, 0% from 0% to 50%. Initial pit caries lesion could exhibit histologic dentine penetration. Likewise, 50% to 88% of ADA classification, caries classification, moderate pit caries lesion because they are fully cavitated. would be expected to have 100% histologic penetration to dentine. Consideration of these probability ranges for dentine demineralization could be beneficial in any caries management system that includes treatments consideration. Lastly, the topic of longitudinal assessment of activity deserves discussions. The World Dental Association caries classification scores visible changes in tooth structures and therefore cannot score initial caries activity before visible structural changes occur. Where there are visible signs of caries lesion, it's often possible to determine whether the lesion is active or arrested. The list factors to consider when making a clinical determination of lesion activity or inactivity. The lesion is judged as can be followed over time to further determine the presence of disease activity, which may influence the decision regarding non-surgical or surgical intervention. Detection of arrested described in time that has been exposed to bacterial acids but is not yet infected by cariogenic bacteria. Depending on clinical assessment of caries lesion activity over the time of examination, affected dentine may be soft if demineralization is occurring or active, or may be hard if the lesion is arrested, remineralized, inactive. Affected dentine often is stained or discolored, which is not necessarily a reason for surgical removal, particularly of the dentine has remineralized. Caries lesion activity assessment, despite the limitations of this metric, may be a key factor for monitoring non-cavitated lesion progression or regression over time, and lesion activity also may be a useful metric for gauging chemotherapeutic treatment effectiveness. Lesion activity should be considered when performing a direct clinical examination and when evaluating radiographs. Evidence of lesion activity over time based on changes or lack thereof in the radiolucency, progression or arrest could have a direct impact on clinical treatment decision. An arrested remineralized non-cavitated lesion, white or brown, is acid-resistant and no longer is indicator of active caries disease. This factor should be considered when assessing caries risk status. Cavitated lesion by nature is more likely to be active and progress because self-cleaning is difficult. The best predictor to future caries lesion in the presence of current caries lesion or evidence of caries lesion if there isn't past. Those careful clinical hard tissue examination must be part of diagnosis and risk assessment. The assessment process includes identification and classification of the presence of lesions, including white spot lesions, recent restorations due to caries disease, cavitated lesions, and radiolucencies. During the clinical dental examinations, they involve tooth surface or surfaces, the site of origin, the extent, and if possible, the activity of any caries lesion should be recorded in a reliable and valid way to assess current disease status as well as changes in disease state over time. The WDA association is proposed to facilitate such assessment. For a lesion accessible via visual and tactile evaluation, which very often excludes the proximal contact area, the clinicians can directly evaluate the lesion. When conducting the visual examination, the clinician should use a good source of light and air on a clean tooth. Forcing and explorer into any site to detect a lesion may cause cavitation and eliminate the chance to remineralized and previously intact surface. However, a rounded, blunt, dull explorer or a ball probe can be used to evaluate surface texture by dragging the instrument arm with the surface in questions. The visual and tactile examination of the teeth is enhanced when the clinicians clean the caries, the pits and fissures while recording findings tooth by tooth to determine if each pit or fissures is sound or if a caries lesion is present. Noting the lesion external, initial, moderate, or advanced, and when possible, recording activity of each lesion as shown. In comparison to the patient's previous examination, finding will help assess caries lesion activity. Note that for surfaces, not teeth, where more than one distinct independent lesion is present, each lesion is classified. Next, the smooth surface are examined by drying the facial the facial aspect and proceeding around the dentition. The practitioner would, when performing periodontal probing, eventually transitioning to the lingual surface, again recording tooth by tooth the status of each lesion, and where possible recording activity with particular attention to changes over time. Lastly, the proximal surfaces are examined using the visual and tactile methods where possible. When direct access is limited because of adjacent tooth contact, radiographs or elastomeric tooth separation can be used for examination to record the status of each lesion. When sequential radiographs spanning the appropriate amount of time, as indicated for each patient, are available for an proximal caries lesion, may be used to determine the radiographic progression or regression and therefore the activity of that caries lesion over time. Note that additional evidence-based adjunctive aids to detect caries lesions, such as fluorescence-based techniques or other light-based caries diagnostic tools, may emerge and they are developed, clinically tested, and validated. They may contribute to a more precise placement of caries lesion in their World Dental Association classification categories. If a caries lesion involves two or more tooth surfaces and two or more surfaces are obviously conjoined clinically, the surfaces are recorded together as a single unit. However, only the most likely site of origin would be recorded for that lesion. For example, a single lesion consisting of the meso-occlusal surface together. Those creating a single advanced caries lesion due to be active to have started on the proximal surface would be recorded in the following manner. For example, meso-occlusal surface, proximal region, advanced extent active. Each site of visible change can be scored as inactive I or active A. Now, note that active activity cannot be determined by radiographic appearance except in situation in which it is possible to compare sequential radiographic images of the same caries lesion exposed over an appropriate span of time. In the if the practitioner is unable to determine the activity level for caries lesion using the activity factors for the gradual radiograph, the lesion activity is recorded as undetermined UD. The dentists decide not to assess activity level for a lesion where such an assessment is possible using for radiographs. It is recorded is not recorded. NR. Details of the most effective methods for recording caries activity will be better developed during actual World Dental Association testing. The following The following and additional examples of caries lesion classification recording using the ADA CCS as detailed in this table. Facial surface speed and fissure origin, initial extent inactive. The next type, occlusal surface speed and fissure origin, advanced extent active. Facial surface, cervical smooth surface origin, moderate extent inactive. Facial surface root origin, moderate extent active. Distal surface, proximal origin, moderate extent active. 2 by twin radiographs taken 1 year apart support the clinical judgment of active based on progression of caries lesion displayed on the wide wings and consistent with the moderate extent based on the factors for this caries lesion. Refer to the examples shown and to the criteria displayed in view edition specific details and examples that illustrate how the World Dental Association classification may be applied in clinical practice. Their proximal site is frequently not accessible for direct examination due to contact with the adjacent tooth. Therefore, other factors for making clinical treatment decision may be useful. In 2002, Pitts and Riemann correlated radiographic radiolucency depth to cavitation. In their study, the radiolucency appeared in the inner one half of the enamel on the radiograph. The percentage of cavitation was approximately 10.8% in permanent teeth and 2.9% in primary teeth. These percentages increased to 40.9% in permanent teeth and 28.4% in primary teeth. These percentages increased to in this the radiolucency extend to the outer one half of dentine and to 100% cavitation in permanent teeth and 48% in primary teeth if the radiolucency extend to the inner one half of the dentine. The World Dental Association caries lesion classification uses a nomenclature that divides the dentine into thirds instead of halves. This nomenclature in E1, E2, D1, D2, and D3. It's simply a way to express the depth of radiolucency as measured of a dental radiogram. Dividing that dentine into thirds rather than halves results in a finer gradation to allow for specific attention to the D1 area where, according to Pitts and Riemer, cavitation is less likely. Radiographic extent is only an estimate on the continuum of mineral loss described previously and may not always fit nearly into one lesion stage. For example, because the middle of the D2 stage is exactly halfway from the dentine enamel junction to the pulp, there may be some early D2 radiolucencies that may not be clinically cavitated, whereas deeper D2 radiolucencies are more likely to be cavitated. The use of tooth separation, where possible, may be helpful in confirming cavitation of a deep D1 or shallow D2 radiolucency. This correlation may be useful when making treatment decisions. It is anticipated that in trying to the World Dental Association classification examination data may be most easily and effectively accomplished using electronic dental records configured with appropriate user-friendly data and dry workflow that offers drop-down pick lists of other straightforward data selection methods. In addition, electronic dental record dry will allow automated use of standardized computable diagnostic coding terminologies to describe the dentist's clinical findings for each caries lesion. Furthermore, electronic entry on the caries lesion data elements will support calculation that over a time span will enable dentists to trend progression or regression of caries lesion. This is analogous to the electronic entry of periodontal probing data in millimeters at 6 points around each tooth to allow calculation of the clinical attachment level of each probed site. Such calculations based on clinical data collected at two different times with an appropriate interim between these clinical observation, improve trending the data to track the progression or regression of periodontal or caries lesion over time. In the absence of an electronic dental record, the dentist can easily implement the World Dental Association caries lesion classification using a paper from a manual calculation regarding caries lesion progression over time. What about caries etiology? And epidemiology, caries and oral mucosal and periodontal diseases are the main cause of oral health problems. They are prevalent in all ages and demographic and socioeconomic groups. You can see on your screen the World Health Organization regional offices and the data which was received by these regional offices for understanding of the widespread periodontal disease, dental caries, and the last oral mucosal diseases. For dental caries, etiology has four main factors: bacteria, time, susceptible to surface, and fermentable carbohydrates. There are four main reasons for appearance the dental caries. It's the effect of time, biofilm formation, role of host, or role of macroorganism, and dietary sugars. Due to the high prevalence of oral disease and increased microbial resistance against antibiotics, there is a need for alternative methods. Therefore, the search of available alternative products is of paramount importance. Phytochemical isolated from plants, which are used in traditional medicine, are considered to be safe and effective alternatives compared to synthetic chemicals. This situation diverted efforts toward finding natural products as a potential medicine for treating dental caries, periodontal diseases, and oral mucosal pathology. A wide variety of secondary metabolites in medicine plants having in vitro antimicrobial activity provide a hope for novel drug compounds. Oral disease, a major health issue in the world, are economically affecting people of developed countries as 10% of the health expenditure is related to dental care. Even though there is an improvement or in oral health in most of the developed countries, there are still dentally disadvantaged people, usually with low socioeconomic status. Caries and oral mucosal and periodontal diseases are the main oral health problem in the world, and exactly in the development countries. They are prevalent in all ages and demographic and socioeconomic groups. Irrespective of geographic location in the world, both males and females are affected from this condition. Dental caries is most prevalent in Latin America, South Asia, and the Middle East, at least common in China. Dental caries increased with age due to denture use and poor hygiene. The presentation of caries varies among people, but the risk factors and developmental stage are the same. According to its survive by the National Health and Nutrition Examination survive conducted among adults between 20 and 40 and 64 years old. There was a decline in causes up to 97%. in 2020, but still their prevalence is high, affecting 92% of people. In developing countries, this percentage rose to 96%. Oral diseases like tooth loss, oropharyngeal cancers, dental caries, oral mucosal and periodontal diseases, and HIV/AIDS related oral diseases are the main public health problems globally. Out of total 291 diseases and injuries evaluated in global burden of disease, untreated tooth decay had the highest rate of prevalence between 17 and 90 percent of a population. And is also one of the most common reason of tooth extraction. Etiology of dental caries and the main factors of appearing this dental pathological process. Caries, it's a chronic multifactorial disease which causes destruction and demoralization of hard tissue of teeth by acid production occurring from bacteria fermentation of food. Representing the common factors involved the caries formation, and the caries can appear only after tooth eruption. Biofilms are usually associated with the etiopathogenesis of periodontal disease. In order to survive in an inkle, and the ability of microbes to adhere to tooth surface and multiply in protected environments like tooth surfaces and periodontal pockets is very important. This accumulation of microbes on the tooth surface is called plaque. Plaque, which can be defined as the structure entire in which the microbes are embedded in a highly organized intercellular matrix. These microbes are involved in different metabolic, physical, and molecular interactions. This consortium provides advantages to the participating microbes for resistance to antimicrobial agents, increased pathogenicity, growth, and host defenses. Four stages involved to the biofilm formation are summarized on this slide. The first stage, it is attachment to tooth. The second stage, log phase, is growth of microbes association. So third stage, stationary phase, it's the maturation of microbes, and fourth stage, it's or death phase, it's erosion of tooth. The primary colonizers of tooth form the biofilm by outer aggregation and co-aggregation, resulting in different morphological structures. The microenvironmental moves from aerobic to facultative anaerobic. The bacteria multiply and in matured biofilm occur. Quorum xanthin is another important characteristic seen in biofilm-associated bacteria, which actually involve the regulation of specific gene expression. This occurs by means of accumulation of different signaling compounds that facilitate the intercellular communication. This gives biofilm their unique characteristics. This scheme showed There are general and there are local reasons or etiological factors for appearance dental caries. It's a host habitants, it's microbes and host phenotype of dental caries. DNA, metagenomic, RNA, metatranscription, proteins, metaproteins, proteomic, metabolomics and metabolites. Except these features, it's transcriptomics, genomics, carioslation, supragingival dental plaque, acute enamel pellicle, and saliva. You can see there are local features and there are necessary general features or general etiological factors, because we know that the caries, it's a multifactorial processes, and not only in the oral cavity exist the reasons for appearance of dental caries. For microbiology, a microbiological etiology of dental caries. The interaction between bacteria and its surrounding epithelium is acute elements in bacterial infections. If left untreated, infection and tooth loss, depending on the severity, will occur. Dental plaque is a sticky substance that sticks to the surface of the teeth. It is considered as complex biofilm that although the main cause of dental caries. Dextran, produced by the dietary sucrose fermentation by Streptococcus mutans, is responsible for the thickness of plaque. As a result of fermentation, Streptococcus mutans produce lactic acid, which ultimately starts enamel decalcifications. This plays a role in initiation of enamel caries. In fact, the development of dental plaque depends on the result of interaction between the plaque adhesion to the tooth surface and the physical shear forces involved in dislodging and removal of plaque. If the dental plaque is not removed properly, tooth decay will flourish. The mature dental plaque is embedded in a matrix of bacteria and host polymer that includes proteins, DNA secreted by cells, and polysaccharides. This provides a protection of bacteria against host defense and predators from desiccation and enhanced resistance against antimicrobial compounds. For decades, the sugar fermenting acidogenic species Streptococcus mutans has been considered the main causative agent of dental caries, and most diagnostic and therapeutic strategies have been targeted toward this microorganism. However, recent DNA and RNA-based studies from caries lesion have uncovered an extraordinary diverse ecosystem where Streptococcus mutans accounts only a tiny fraction of this bacterial community. This supports their concepts that consortia formed by multiple microorganisms act collectively, probably synergistically to initiate and expand the cavity. On your screen, you can see the diagram which shows that many types of microorganisms, except Streptococcus mutans, formed different microbial cariosogenic community. Streptococcus mutans, Streptococcus mitis, Streptococcus constellatus, sanguis, salivarius, anginosus, gordonii, intermedius, oralis, and some of the primary acid-tolerant bacteria that are associated with dental plaque. Accumulation of plaque in gingival and the subgingival regions shift their microflora from gram-positive to gram-negative. This can cause periodontal diseases and dental caries. Dental caries is linked with the high blood pressure, diabetes, heart diseases, and sometimes multiple sclerosis, along with continuous pain that gets aggravated by cold, head, sugar, and drinks. Four main factors are associated with dental caries etiology. These factors are bacteria, time, susceptible to surface, and fermentable carbohydrates. Along these Along with these factors, there are certain behavioral and socio-demographic factors that are likely to increase the risk of caries. This includes poor oral hygiene, first of all, improper toothbrushing habits, plaque, and sugar-containing drinks. The oral cavity of human is considered of a complex ecosystem which is the both acid-producing and acid-tolerant bacteria. Almost 700 different bacterial species have been known for human oral cavity, and nearly 200 to 300 species have been identified for dental plaque using different cultural dependent and culture independent techniques. Streptococcus mutans is considered as the main organism responsible for human dental caries. Certain factors like ability to form biofilms, tolerance, tolerance of frequent and rapid environmental fluctuation, and metabolizing carbohydrates are considered to be responsible for the virulence of these bacteria. In addition, the mutants is also associated with bacterial endocarditis, inflammation of heart valves, synthesis of the extracellular polysaccharides by Streptococcus mutans from sucrose glucosyl transferases is considered another important virulence factor that causes caries in humans. This not only facilitates the adhesion and accumulation of the organisms in the tooth surface, but also provides protection against the host immune defense, along with provision of increased resistance against antibiotics and gene expression. These combinations of virulence properties allow the mutants to colonize the surface of tooth and modify the non-pathogenic to highly carcinogenic dental biofilm that ultimately leads to caries formation. Caries can be defined as the result, the signs and symptoms of a localized chemical dissolution of the tooth surface. Surface caused by metabolic event taking place in the biofilm, dental plaque covering the affected area. This is contrast to the process of dental erosion, where the tooth demineralization occurs with the acids derived from plaque bacteria, but form acid food, beverages, etc. Clinically, dental caries and dental erosion have different appearance and outcomes on their teeth. Under healthy conditions, calcium and phosphate ions from saliva remineralize the tooth surface constantly. Remineralized the tooth surface constantly. After which is in equilibrium with the constant demineralization of the tooth surface caused by bacterial acids or acid derived from diet. You can see on this scheme hydroxyapatite and fluorapatite. It is the main waves of enamel remineralization or resistance. Structure of hydroxyapatite. You can see 3D variant of hydroxyapatite structures. The hydroxyl ion located in the central C-axis is surrounded by calcium and phosphates and by the hexagonal of calcium. The scheme B showed it's a representation of the remineralization process. There is replacement of the hydroxyl ion by a fluoride ion in the center of the molecule. The green color marked the fluoride compounds. However, although super saturated with calcium and phosphate ions in a bioavailable forms. The cellular remineralization process is slow and insufficient to tackle the caries process alone. Moreover, a major thick and sticky plaque, as seen in poor oral hygiene conditions, it takes a long time for saliva and salivary components to penetrate, though the dense layer to reach the tooth surface to induce remineralization. Sucrose and other monosaccharides are readily taken up by plaque bacteria and metabolized to organic acids. These acids will slowly dissolve enamel crystallities. In high-risk patients, such as patients undergoing an orthodontic therapy, clinical visible caries lesion can develop and be diagnosed within just 1 month. Bethel and Schumann analyzed the caries susceptibility of different tooth surfaces in children aged 5 to 16 years. These researchers found that the most susceptible group consists of thick tooth surfaces, the buccal, pits, and occlusal fissure surface of the first molar. The second group consisted of 20 sites on the second molar and premolar. This group formed by the least acceptable sites includes the largest number of tooth surface and consist of the majority of the lower anterior teeth and canines. Additionally, the also called early childhood caries, ECC, mainly affect the upper incisors. However, it should be emphasized that all teeth can be affected by caries. What all tooth surfaces that are often affected by caries have in common is that the dental plaque removal seems to be insufficient. Caries is the dental disease affecting billions of individuals around the globe and having a huge negative impact on the global level of health. Every person is prone to dental caries at some time in their life. There are also several patients groups are especially at risk of development caries, such as following: children and adolescents. Diet might contain high sugar amounts, toothbrushing time is limited, and plaque removal is inefficient. Not only the amount of sugar, but also the frequency is important. Toothbrushing technique may not be sufficient for efficient plaque removal. Patients undergoing orthodontic therapy, orthodontic appliances, especially braces and brackets, made difficult patient to remove plaque appropriately. Brackets increase dental plaque built up, which increase caries risk. Patients suffering from hypomineralized teeth. There are several known conditions that may cause developmental hypomineralization of the teeth. Molar hypomineralization, until recently are often called molar incisor hypomineralization, is one of the most prevalent developmental defects of tooth enamel, DDA. However, all affected persons have one thing in common, which is tooth sensitivity. This leads to diminishing brushing of the teeth and reduced plaque removal. Additionally, hypermineralized tooth structure are prone to develop caries. The mineral content is deficient and enamel integrity is not intact. Following this, acids can dissolve less mineralized enamel faster than healthy enamel. Patient with reduced salivary flow, hypersalivation. Saliva protects and remineralizes teeth, while saliva helps reduce the carcinogenicity of sugars. Reduced salivary flow results in diminished antibacterial effects because of the inefficient dilution of acids, diminished buffering capacity, and lowered remobilization potential. Dental plaque built up is increased. Taken together, this leads to an increased caries risk of the affected person. Elderly with exposed dentine. Exposed dentine is more prone to developing dental caries, and the mineral contents and density of dentine is reduced compared to enamel. Also, the critical pH for dentine dissolution is 6.2, unlike that of enamel, which is pH 5.5. So dentine demineralized easily when exposed. Additionally, elderly people suffer in many causes from hypersalivation and may not be able to brush their teeth properly due to physical limitations. This type of dental caries is also known as root caries. As a result of the research, a certain connection was found between the level of anxiety and the structural and functional acid functional resistance of enamel and low resistance of teeth to caries have a higher level of both reactive and personal anxiety compared to children with significant and moderate structural and functional resistance of enamel, and accordingly high and medium resistance of teeth to caries. The obtained data can be the basis for sustaining and prevention of dental caries in children with various psycho-emotional states or psycho-emotional stress. The processes of demineralization is a gradual process that leads to the gradual dissolution of hydroxyapatite crystals in enamel, resulting in the loss of tooth tissue. This process will be discussed extensively below, along with its causes. Demineralization of enamel and dentine appears to be an increasingly common problem. Despite technological development in oral hygiene and awareness campaigns, the main consequences related to it are increased dentine sensitivity and the development of dental caries. Dental enamel is a cellular hard vascular tissue consisting of 96% inorganic materials, hydroxyapatite nanocrystals, 3% of water and 1% its organic compounds. The enamel protein matrix is produced by enameloblasts and later mineralized though calcium phosphate crystals. Enamel is an acellular tissue in that enameloblast die soon after producing it. Its highly mineralized structure makes it one of the hand very resistant, and on the other hand, susceptible to the phenomenon of demineralization. Enamel doesn't possess precise color, but has a fundamental property called translucency. It's the typical characteristics of enamel and is closely associated with the structure of dental enamel itself. Specifically, translucency is an optical effect that is closely depended on the spaces between hydroxyapatite crystals. In the early stages, to clinically accurately identify caries pathology, it was necessary to dry the enamel surface. With the progression of caries pathology, however, the spaces between enamel crystal widen. This change resulted in the formation of a chalky-looking lesion even without drying of the surface, which appears distinguishable from the surrounding healthy enamel. Translucency is lost when the dehydration of dental enamels begins. They occur as a result of the gradual replacement of water by air between the space present between enamel prisms. Translucence can be defined quantitatively by the enamel refractive index, ERIs. Specifically, the refractive index is the ratio of the speed of light in a vacuum to the speed of light in the medium traversed. The denser the material, though which light passes, the slower the passage and propagation of light, though that body. Dental enamel has a refractive index of 1.65. Because water has a refractive index of 1.33, the air has a refractive index of 1 greater. Scattering occurs at the enamel-air interface. The main function of enamel are to protect dentine and pulp from thermal shock, mechanical stress, chemical corrosion, and bacterial infection. One of the main causes of occurrence of caries lesion resulting of the loss of tooth structure is attributable to the presence of bacteria. Different types of microorganisms constitute the biofilm that adheres to the tooth surface. These microbial colonies stabilize the oral pH and protect the environment from exogenous and pathogenic species. Disruption of this balance is a result of complex interaction between heart tissue, biofilm, and metabolic processes. Fluoride's influence on the structure and stability of two minerals, as well as its absorption into the development mineral, has been the focus of much research in dentistry due to these ions' well-documented karyostatic action. Among the endogenous causes attributable to tooth surface demineralization is gastroesophageal reflux, while an exogenous cause is the diet high in sugar, especially if it is not followed by proper oral hygiene. Cariogenic sugars are introduced into the oral cavity. A diet rich in sugars favors cariogenic bacterial metabolism, which becomes the predominant strain in the biofilm that covers the oral surfaces. The later setting on the both teeth surface damage it. If this process is not stopped or limited, it leads to the occurrence of cavitated lesion. The crystal structure of hydroxyapatite exhibits a planar hexagonal nature of calcium and phosphate ions surrounding the central hydroxyl axis. During remineralization, fluoride is classically incorporated by replacing or displacing hydroxyl ions. As a result of fluoride incorporation, calcium phosphate covalent bonds and or H fluoride hydrogen bonds are formed, and the unit cell volume of the epitite is reduced, increasing the hardness and acid resistant chemical durability of dental enamel. As a result of another important function of fluoride ions is to act as antibacterial agents and as inhibitors of the bacterial enzyme enolase, resulting in reduced acid production by bacteria. After reviewing these studies, it can conclude that CPP and ACP-based remineralizing agents remain the gold standard in clinical practice, especially when combined with fluoride-containing agents. Nevertheless, from the reviewed studies, excellent results were also obtained in treated WSLS with ozone therapy, hydroxyapatite therapy, and sealants. Given the universe and heterogeneity of the analyzed studies, it's not possible to establish the superiority of one remineralizing agent over another, and only complex influence on the healthy dental enamel can lead to the enamel resistance and disappearance of dental caries. Thank you for attention.